Hey guys, am I audible and visible? Sorry for the delay. Am I audible? Hello, developer king ruler. Thank you. Develop something great. I also will become a fan. Fine. So let's start. So guys, did you read the FGT and breast today? I had given you a tiny schedule, like a 45-minute session. That should be actually enough to read for both FGT and breast. Nothing else is required. So I had given you few clinical scenarios as well. Quite a few of you commented. Many of you didn't comment. Next time I want everyone to comment so that if there is a see, you will definitely make errors, right? The only way to improve is making errors now and not in the exam, so that every error which comes in the exam is already been made here in our discussion, so that you don't make any errors and you sail through your exam peacefully. Fine. Okay, good evening, hi, and yes, Krishna, thank you. So what we'll do is we are going to look at the few clinical scenarios which I shared in the Insta and WhatsApp groups. Then we'll go with few templates, like I would majorly discuss on 3 major topics and maybe a couple of small topics as well. Fine, let's go ahead. So this was the first question I think I posted in the Insta and the WhatsApp group. Guys, answer. It's a very simple thing. I'm sure you know the answer, right? But the answer format is more important than a long answer. This was the clinical scenario. Let's assume how did you come to a diagnosis, right? So what are things important for me? Elderly is important by default. 60 year, especially when you are thinking of a cancer because of thickened endometrium and irregular borders and extension into myometrium, right? So primary, I am going to think of a cancer. So obviously I need one thing, which is the age. And there's a history of metabolic syndrome X. When I say metabolic syndrome, obesity, diabetes, and hyperlipidemia, all these are classical kind of initiating factor for your type 1 endometrial adenocarcinoma, right? And there's an abnormal uterine bleeding, that could be the history. An abnormal uterine bleeding in the history given, and an investigation, classically a thick endometrium with irregular borders. And the most important is the next one as well, invasion into myometrium. Everyone comment what is one finding you definitely can say it's cancer. One finding or the hallmark of any cancer or any carcinoma is invasion, right? Invasion by default is the hallmark for any carcinoma from head to foot. So invasion into myometrium is a classical finding seen in case of endometrial carcinoma. Do add that as well, and please write in bigger letters, right? So extension into myometrium helps me to more concretely to say it's an endometrial adenocarcinoma, right? Perfect. See, if you want to score a little bit more, right? Can anyone tell me, is it type 1 endometrial adenocarcinoma or type 2 endometrial? Endometrial adenocarcinoma is more than enough for me for diagnosis. If you write it's an endometrial adenocarcinoma, that's more than enough. Or even if you use the term endometrial cancer, right, that's also more than enough, because unless I take a microscopy, I will not be able to say adenocarcinoma or cancer, right? So just an endometrial cancer, that should be enough for us. It's type 1, right? Most likely a type 1 endometrial adenocarcinoma, fine. Some of you might think of type 2 because of the age of presentation. Remember, this is the age of presentation. Doesn't mean that the patient had the pathogenesis 60, right? The patient might have had the pathogenesis starting at 45. Patient must have not come to us, or every cancer has like 10 years of slow, very latent progression, right? That's why the patient presents at 60. By default, the problem would have started much early because of obesity, hyperestrogenism, everything points out to type 1 endometrial adenocarcinoma, right? Perfect. If you write this, great. Otherwise, just a term endometrial carcinoma or endometrial cancer is more than enough for us, fine? Okay. This is the second question which I posted. Answers? Anyone? I'm sure this also is an easy one, right? I think it becomes easy when I post along with what subject we have to study, right? I think once we finish the Farre, if you have time, we'll have some random clinical scenarios. Okay. So again, reproductive age group, that's one key finding here. You can write as 30 or you can write as reproductive age group, fine. Okay. With a long-standing history of painful menstrual cycles, right? Painful menstrual cycle is the classical history with worsening pain and dysmenorrhea, right? There are cramps which is there, that's all, fine. So on ultrasound, it reveals an ovarian cyst. You can write that. When I say homogeneous low level echoes, which means it's most likely a fluid. It's a fluid filled cyst. We cannot say the fluid is clear or blood. We'll not be able to say it on ultrasound. It's a fluid filled cyst. Heterogeneous areas mean solid and cystic areas. It's homogeneous. low level echoes. You'll read them when you go to final year, but here, this is what my interpretation is: a fluid filled cyst. A fluid filled cyst with pain, dysmenorrhea, dyspareunia, dysmenorrhea, uh, dyspareunia, and a little bit of infertility if it can add on, as a classical diagnosis of, like you guys said, endometriosis, right? Endometriosis is unlikely to come in a long answer. It's most likely a 5-mark question. There's nothing much to write in endometriosis in a long answer. But if it comes in a long answer, presentation is very important. Take whatever data is given, use whatever word you want, history or dissecting the history or approach to diagnosis, whatever. But these pointers are very important. So the first impression in a long answer you take from the question given. So it gives a very good impression to an examiner. Be it right or wrong, at least your approach is right, they'll give a good mark. Fine. Okay. This is that question. Diagnosis. Developer, I didn't put the cervical cancer here. Probably simple one, right? So if I'm elderly with a family history, there is a family history of breast cancer, that itself tells me most likely it's going to be breast cancer. A painless, that's important. A firm lump, firm is also important in the right breast, right? Mass with a retraction of nipple. That also is a very classical finding. If you have gone to your surgery postings, nipple retraction is one of the classical findings seen in case of a breast cancer. By default, with the family history and this thing, with the speculated irregular margins, your diagnosis has to be a breast cancer. Here, I would not say to write as in familial breast cancer. I will not be able to say it's familial breast cancer. That's enough. Okay. Definitely develop king ruler. You can definitely say it's a chocolate cyst. Okay, because endometriosis of ovary is equivalent to chocolate cyst. Whether it is hemosiderin seen there or not with history, endometriosis of ovary is called as chocolate cyst. You can write as chocolate cyst by default. Okay. Chance means, what do you mean by chance, Samantha? See here, it can be endometriosis or an ovarian endometriosis or a chocolate cyst. Both means one and the same. You can write that. Okay. Fine. So these are the few things which we have shared already, just a way to discuss them, right? Now let's look at a format, especially when you have a cancer cases, right? If a long answer is cancer, like we saw format for glomerulonephritis, I want you to make sure these formats are filled for most of the cancers. If a cancer question comes in a long answer or a short answer, if you have 4 or 5 headings, that's more than enough, fine? Okay, so risk factor or etiology, whatever comes easy for you. But I would say risk factor will be a better one compared to etiology. Pathogenesis and progression. See, if a cancer question is coming on a long answer, can I say by default for every cancer from head to foot, there'll be a precursor lesion? Okay. Can there be a precursor lesion? Yes, right. Let's assume it's a simple lung carcinoma, squamous cell carcinoma of lung. So it could be normal. It could be squamous dysplasia, right? It could be then full thickness dysplasia or a high grade dysplasia, then a cancer. Okay. If it's an adenocarcinoma of Barrett's esophagus, again normal, low grade, high grade dysplasia, carcinoma. Every cancer from head to foot by default will have a history, will have a progression. That progression is very, very important. Either write the progression as such, or if you know any genes which cause the progression or any risk which caused the progression, like a smoking caused it, something else caused it, write that also, right? Because most of the cancers, I have an papilloma carcinoma or an adenoma carcinoma sequence throughout the body. So progression is very, very important. Cervical, I have normal, L-cell, H-cell cancer. Endometrium, I have normal, a typical hyperplasia, atypical hyperplasia cancer, right? For everything, I'll have the progression. That progression is important. Pathogenesis also. What if you know a classical gene, write the pathogenesis. Classical thing, write the pathogenesis. If it's not a classical thing, just few risk factors, need not write more about pathogenesis. Clinical history by default should be there. That should be the step heading before describing the gross and microscopy. Always before, don't put clinical history last. Lab findings by default is required, right? See, these are something which we can create a template for every cancer. For any cancer, can I say biopsy is diagnostic? Yes. A patient with breast cancer, the breast mass comes to you. What will be the first thing which you will do? Anyone with a breast cancer, you see in an OPD patient, a patient has some breast mass, 65-year-old. Examination, definitely a biopsy. Write that. Everyone knows it's a template. I can write this template for every cancer from head to foot. What will change is the modality of diagnosis. I can do a true cut biopsy in case of breast cancer, right? developing, it'll be TRU. Fine. It's a true cut biopsy. Fine. And we can have an endometrial biopsy hysteroscopy for an endometrial carcinoma, cervical colposcopy guided biopsy for a cervical carcinoma, right? But that will be there, right? So you have clinical information, then lab diagnosis. If it's in thyroid, FNAC, lab diagnosis, right? Then gross. Gross, again, for every cancer, you can write a template, fine? Great, Kamran. Good evening, Kamran. Yes, you can write this, Shanak, fine? So for gross, it's very simple. I'm giving you a template. You can use this for any cancer from head to foot. Let's take one random cancer and see if it fits the template. I'm having an esophageal cancer, which is not a very important thing for you guys, but we have an esophageal cancer. Can this cancer grossly have proliferating lesion? Is that possible? Yes. Can this cancer kind of have an ulcerative lesion? Is that possible? Yes. Can this cancer just have kind of an infiltrative lesion? Is it possible? Yes. Any cancer, if it is on a surface, not like ovary cannot ulcerate, right? If it's on a surface, like an epithelium, any epithelial surface will have an ulcero-proliferative type. It will be there by default. It can be an ulcerative type, just an ulcer. One can be proliferative. It can be infiltrative type. This you can write for every cancer which arises from an epithelium, be it an oral cavity, be it your larynx, pharynx, esophagus, throughout the GIT, cervical, anal canal, penile, anywhere this pattern will be fitting in. Don't worry about it. If it's a breast, this is not important for me, mass lesion, right? So few areas is not important for me, but quite rest of the majority of the cancers, this will definitely fit in, right? That's for gross finding, right? Microscopy, you know the patterns. See, in an infiltrative, generally it's only in duration, right? Okay, it's only in duration, it'll be just thickening. That's what infiltrative means, right? Big ovaries generally don't ulcerate because they grow as a mass. If they ulcerate, it becomes a very high grade cancer that is in the terminal T3 stage of ovary, where they can still ulcerate, can go into the peritoneal fluid. But early stages, it might not ulcerate because it will be covered by the ovarian's capsule. That's why, fine? Okay. Microscopy, you have the patterns. I want you to go through the patterns of microscopy in the MedEd recorded lectures. Go through that. It will give you 24 patterns. You can write any pattern. Again, for microscopy, I have a template. Microscopy always starts like this. Put the pattern, whatever pattern is, adenocarcinoma glands, squamous cell carcinoma, or keratin pearls, blastoma, small round blue cell, carcinoid nesting pattern, then pleomorphism, increased NC ratio, mitosis, loss of polarity. That's all. The same 4 findings plus add invasion. Invasion of the particular structure. If it's endometrial, invading into myometrium. If it's your, let's say GIT, invading into lamina propria. If it's your skin, invading into dermis, right? Invasion by default. This gives you classical 4 pointers for any microscopy of any cancer from head to foot. Then types. If there are any types, write the types. Endometrium has types, right? Breast cancer has types. Write a word about types. IHC, if you know, write. If you don't know, ignore it. If you want to add IHC, again, I'll give you a simple rule. If it's a carcinoma, can anyone tell me at least one IHC for every carcinoma and one IHC for every sarcoma, which are not specific, very, very sensitive? I have an IHC called as cytokeratin. This is IHC for every carcinoma, and you have an IHC called as an vimentin. This is IHC for every sarcoma. If you have forgotten the right IHC, use this. If you remember the right IHC, that's completely fine. Just write the right IHC, that's more than enough. If you've forgotten, use this just to fill the pages, that's all right. This template again will help you to swim through any question in cancer. Don't worry, we have templates for everything. We'll use the similar same templates. Just a little bit tweak here. 5-mark question, you write 6 headings and 1 point under every heading. You are bound to get 3.5 4 marks. Exam, especially university exam, is very, very simple, right? NEET exam is little bit difficult compared to university exam. Come outside in practice, that's the most difficult, and I'm sure you'll ace that, right? So let's go with the same template with the first thing, cervical cancer. Risk factors, you guys know. I'm just going behind. I want you guys to comment. Tell me what are the risk factors which comes into your mind for cervical cancer, because you must have read this is a revision session for you. This is not a class for you. Cervical cancer risk factors. Definitely everyone knows HPV is the reason, the etiology. So multiple sexual partners, very early sexual activity, multiple sexual, be it men or women, both of them can have, and definitely by default, it's a HPV. The persistent HPV infection is the concern for me, right? So multiple sexual partners, early sexual activity. If you want, you can write unprotected sexual activity. Smoking is an associated factor. What I mean by associated is smoking alone cannot cause cervical cancer. I need this person. Without this, I cannot have it, right? So if you want to add extra, you can add this 16 and 18. If you don't want, you can just add, right, HPV. That's more than enough, right? I would prefer if you write 16 and 18. Okay? Fine. I would prefer 16 and 18 alone, right? So can anyone tell me what are the low risk phenotypes? The low risk phenotypes are HPV 6 and 11, which causes condylomas or warts. Fine. So these are risk factors. Risk factors will easily give you half page. If you want to write, you can add a little bit more. If you know HPV, you can easily by default write this patient, HPV is a sexually transmitted virus. That's the reason multiple sexual partners and early sexual activity has an increased risk of developing cancer. That's all. Smoking can contribute. Immunodeficiency. If you want, add how immunodeficiency can contribute, because it can increases the persistence of the virus. Only when the virus is persistent, it can cause change. If it's not persistent, it will not cause change, right? I'm not saying that a person with good immunity will totally be free of cervical cancer, but immunodeficiency can contribute to the cervical carcinoma pathogenesis, right? So we know about the risk factors or the etiology. Next is pathogenesis. Pathogenesis is simple. For most of the pathogenesis, we already know from the neoplasia chapter itself, right? The same HPV 16 and 18, both of this will have integrated DNA into the human genome. It will integrate the DNA into human genome. So once it integrates the DNA into human genome, this is very, very important. Only this integration makes them a high risk virus. Otherwise, they'll become low risk virus, right? This integrated genome, DNA in the human genome, will increase the production of viral proteins. Can anyone tell me what are the viral proteins? We know the viral proteins, right? So the viral proteins are your E6 and E7. So next thing, see, in an exam, write this vertically so that you can easily fill 1.5 page, right? That's our ultimate goal, right? So this E6 kind of reduces the activity of P53. E7 kind of reduces the activity of retinoblastoma gene. So by default, if you want, you can extend it also. This will stop. P53 is going to be the most important thing for us, right? The guardian angel. So more and more mutation accumulates, and retinoblastoma, once it's blocked, G1 escape is taken care of. It will go beyond the G1 escape, right? So this will increase the cell division. So whenever cell division is increased, and in the absence of P53, there can be new mutation which accumulates. More and more mutation accumulates, and more and more mutation accumulates, obviously it's going to result in a cancer. Okay. Yes, Vamish, I'm just saying the minimal thing which is required for it to write in the exam. It has E6 as well as E7. Both of them have one more extra finding. If you know, you can write that, right? Mutation accumulate, and which causes the cervical cancer. It's a very simple pathogenesis, right? So I know etiology. Etiology carries, let's say in the long answer, 2 marks. Pathogenesis carries 2 marks. This is enough for a 2-mark pathogenesis, right? If you want, if you're good in drawing and if you have time, draw a normal gene and then virus infecting the gene and draw an integrated genome. If you can, not a must, because these are all gimmicks. I would say that drawing in an exam is just because you don't know what to write. That's when we kind of draw something, right? And let's go to the progression. Like I said, every cancer will have progression. Cervical cancer progression is very, very, very important, right? So if you can draw in the form of a diagram it, draw it, it's more representative. But if you're not good in drawing diagrams, don't attempt it. Write the points. I want you to know what is right. That's all. If that is there in the exam paper, I'll definitely give you a mark, right? From normal, it goes to something called an LCIL. If you want to write the older terminology, write CIN1. Okay. Here, don't waste time writing cervical intraepithelial neoplasia. A pathologist knows that. Everyone evaluates knows what is CIN1. EBV, don't write Epstein-Barr virus. Don't waste time. I know it's Epstein-Barr virus. I know it's LCIL, right? If you know it's LCIL, definitely every examiner will know what LCIL is, right? It's LCIL, that's all. Unless they ask LCIL for a short answer, Then write low-grade squamous intraepithelial lesion. Fine. Then it goes to HCL. Again, the older terminologies, if you want to mention, both CAN2 and CAN3 are high-grade squamous intraepithelial lesion. Then it becomes invasive carcinoma. Invasive, if you want to write squamous cell carcinoma. Okay, that's how the progression. The most common cancer is squamous cell carcinoma. The progression is like this. Fine. Okay, now we have to also tell what does LCL, what does HCL mean. I don't expect you to write this description for every other cancer. I don't want you to know what is low grade, high grade dysplasia and Barrett's. But LCL, HCL, I expect that, right? So LCL is nothing but when you have atypia in the lower 1/3 of your squamous epithelium. That's when I said you can draw a diagram if possible. Draw a squamous epithelium. Okay. Lower 1/3. For me to say it's dysplastic, I need to put it more blue in color. If you can draw cells, it'll be great, but I don't think so. You'll have time to draw that much good amount of cells here, right? Lower 1/3, that's more than enough, right? So here, CAN2 is 2/3 of the epithelium. CAN3 is full thickness dysplasia. Can anyone tell me what's the other name for full thickness dysplasia? When I say full thickness, entire lining epithelium becomes dysplastic. What's the other name? Perfect. You can write that as well. Carcinoma in situ, right? So from carcinoma in situ, automatically it becomes a squamous cell carcinoma. Squamous cell carcinoma is only 1%. That's invasion. So when I see invasion, I can definitely call it a squamous cell carcinoma by default, right? This is the progression of squamous cell carcinoma. In the pathogenesis, it can easily give you 1-2 marks because see, these are just 4-5 points, but everything are most important points. In an exam, that's what's required. Don't write paragraphs. No one is going to read paragraphs. This itself is very, very difficult for me to read, right? Because every paper it will be the same. So it's difficult. So please consider the examiner's mindset also and write accordingly. Like I said, after risk factor, your pathogenesis and the progression, clinical features. Postcoital bleeding is a classical clinical feature. Fine. Sure, Aparna. Don't be scared. Start reading. 30 days is more than enough. Fine. Postcoital bleeding. That's the classical finding for most of the cervical carcinoma, right? So let's assume a patient came with an history of postcoital bleeding. What will be the first thing you do? You won't take a biopsy, right? You will examine the patient, right? So first is examination. It will be followed by examination. In examination, based on the finding, I will go and investigate, right? In examination, if there is no visible mass, let's assume it's just a cervix. In examination, there's no mass in the cervix, right? So can I take a biopsy randomly? No. In your gynecology, have you heard something as an acetic acid inspection? Have they taught you that? If they're not taught you, just remember this. So what I do is, there's something called a visual inspection of acetic acid. Okay. Postcoital bleeding, it's a symptom after coitus, right, Punit? So the patient is going to come to me, even if there's an acute bleeding, you will take from a very maybe a little bit of solid area, not from a very fragile area. Again, biopsy itself will bleed. So anyway, we're going to suture it. So it's not a problem, right? Perfect. So if there is no visible mass, that's very, very important. You do a visual inspection with acetic acid and then take a biopsy. But on the other hand, here you can draw a diagram, right? I will do an examination. There's no mass here. Then draw as visual inspection with acetic acid. That will give you my classical site. Take a biopsy. Again, on examination, if there's a cervical tumor with a proliferative mass in the anterior lip or posterior lip, whatever it is, there's a mass present. If there's a mass present, again, it's very simple. I don't want a visual inspection. You take a biopsy directly. Ultimately, it's biopsy. That's how we're going to investigate, right? Again, pictures are more representative. Flowcharts are more representative. Need not be beautiful pictures. Draw with single color enough. Need not be more expressive there. Single color. I just want you to know what you're going to convey. That's all, fine. I have a mass. Now you take a biopsy. Gross, it's a squamous cell carcinoma. Can I have the same 3 templates here? Proliferative, ulcerative, infiltrative. Can it be there? It can be there, right? Grossly, you can have the predominant here is squamous cell carcinoma, right? So grossly, you can have an ulcerative growth or an ulceroproliferative growth. Mostly ulcerative and ulceroproliferative are the most common things, right? VIA stands for visual inspection after acetic acid. Okay. Then, or rarely I can have infiltrative growth pattern as well. So infiltrative growth pattern is where visually I will not see any lesion. It will be just thickening. That's where I need acetic acid to use that. Fine. Yogesh, it's not for you. You will read them when you go to gynecology. It's a gynecological thing. So it's an investigation, right? Biopsies are taken by gynecologists. I use acetic acid. Acetic acid binds to every area which is good or more nuclear material. Normal cervix, normal nuclear material will not change color. When you use acetic acid, when there's more nuclear material, it changes color. So it's easily makes the job of a gynecologist easy to take to know which site of biopsy, which site biopsy to take. Whenever there's no mass. If there's a mass, no problem at all, right? That's a concept between visual inspection with acetic acid, fine. Infiltrative, okay. This is again for squamous cell carcinoma, which is the predominant subtype, fine. Which point, Shreyas? VIA? If it's adenocarcinoma, okay. Again, adenocarcinoma is not that common, but you can definitely write, because adenocarcinoma is also one of the variant of carcinoma in cervix. Adenocarcinoma might have again a mass with or without mucin secretion, which can be shiny, which can be seen, right? Because adenocarcinomas do secrete good amount of cervical mucin. You can see them. If it's adenocarcinoma, there's a possibility, but adenocarcinoma is less than 5%. 95+% is going to be squamous cell carcinoma with respect to cervix. Fine. Now let's come to microscopy. Microscopy is same template. Simple, right? Again, right? In microscopy is where I said you can write the types as well. Types is important, especially if the question is not on any particular type of cancer, right? Squamous cell carcinoma. Squamous cell carcinoma is the most common subtype. Like I said, more than 95% of cervical cancers are squamous cell carcinomas only. Okay. Squamous cell carcinoma, it's very simple. We have the keratin pearl. We have the 4 features of dysplasia. I'm just writing here 4 dysplasia, but I'm sure in your exam you have to write pleomorphism or write variation in the size and shape and everything. Okay. That's how the patient's present, right, Punit? Postcoital bleeding, the patient comes to us, we'll have to investigate them. Okay. Coilocytic atypia, Shonak, it can write it, but that's not a feature of cancer. That's a feature of HPV, which can be there by default. If you want, you can write coilocytic atypia also, which tells me that it's a sign or it's a disease associated with HPV. That's all. It's not a sign of a cancer. If you're writing coilocytic atypia, write this as well. It'll have a raisin-like nucleus, a raisinoid nucleus, which means a shrunken nucleus, and a clear cytoplasm of the cells. That's a classical feature of coilocytic atypia, which means it's HPV related. That's all, right? And by default, I need invasion. Okay. Second, adenocarcinoma. So like I said, types are very important. Though it's not a more common, right? You can write here glandular tumors with invasion. That's more than enough. Need not explain the 4 features of dysplasia here again. Third, very rarely I can have small cell carcinomas as well. Can anyone tell me how does a small cell carcinoma look? I'm sure you must have not read this today. Small cell carcinoma. Small round blue cell tumor. Obviously, it will have small round blue cells. There's one more classical finding which we read in lung cancer of small cell carcinoma. Small cell carcinomas will not have nesting pattern. Small round blue cell, by default, it will have one more feature which starts with A, Z, neuroendocrine granules. You are right, Shanak. I can use that as well. You have the Azopardi effect. If you want, write it, because everywhere small cell carcinoma will have the Azopardi effect. Yes, it will have the salt and pepper appearance also. There's no second thought in that. But this is very, very rare. If you want the distinction or honors, maybe write this, right? Whenever you write a microscopic finding, it's always good to draw a diagram because it's expected, right? So put a square. Again, it's not about being beautiful. It's about being representative, right? So draw a squamous keratin pearl. Draw a squamous keratin pearl and put few cells here. The beauty of carcinoma is it need not be uniform, right? So whatever diagram you draw, it'll become good for it, right? A very pleomorphic cell with a keratin pearl pattern, that's enough for us, right? Again, adenocarcinoma, I'm sure you can write glands with completely ugly nuclei. That's how it is. But one major thing, if you draw, that should be more than enough here. Fine. Okay. Coilocytosis, if you want, that also you can represent in a diagram. For coilocytosis, it's a bit difficult to represent in diagram because for coilocytosis, you have to know the normal cells as well. So which means you have to draw normal cells first with good amount of pink cytoplasm. Then it's very easy for you to appreciate the racinoid nucleus. Shrunken nuclei with clearing. A normal cell will have good amount of nuclei, round nuclei, not shrunken. And here, shrunken nuclei with clearing. Irregular shrunken nuclei with clearing. That's your coilocytic atypia if you want to. Fine. Okay. Since it's cervical cancer question, it's not right if you don't mention the word pap smear. That's by default required, right? Pap smear is a screening procedure. It's not a diagnostic procedure, right? Again, you not write everything regarding pap smear. You can just write this is screening test done for cervical cancer. You can write it's a less invasive or a non-invasive method. Write a few words about pap smear. Draw a cervix. And if you want, use the IR spatula for drawing. Or if you want to draw the cervical brush or the broom, use that for drawing, right? And put a 360-degree rotation. And you make a smear. If you want to write fix with alcohol. See, these are extra procedures, that's all, right? And then look into the microscopy. Pap smear can tell you whether it is normal, whether it is L cell, whether it is H cell, or whether it is squamous cell carcinoma, SCC. Squamous cell carcinoma, I have one classical finding, which is your tadpole cells and a dirty background. This dirty background, the pathologist likes because this is what I look for a pap smear when you see in a microscopy. Dirty background means it's suggestive of invasion. That's what I mean by dirty background. If it's there, I think of squamous cell carcinomas. Fine. Yes, Leon. VAA is more like an step for me to make a better diagnosis, more accurate diagnosis. Vamish, see, HPV is different from L cell. Fine. L cell is an intraepithelial lesion. HPV is an infection. Fine. HPV can be seen in cervicitis. Normal virus infection can be seen. Normal cervicitis also can have HPV. L cell will have nuclear changes. L cell can also have HPV. H cell can also have HPV. Squamous cell carcinoma can also have HPV, right? H cell, L cell is cancer. HPV is infection. Both can coexist. Fine. I've told them, King, sometimes YouTube also does that. I cannot help it. Sorry for it. Keratin pearl is just a pink round. That's all, Samantha. My diagrams will be the worst. Please don't take inspiration from my diagrams. Fine. Okay. Just last but not least, if you want to add an IHC, I should have written about the microscopic finding. There is a marker called as P16. P16 is important. This is a marker of HPV. What's the marker for squamous cell carcinoma? Anyone? For squamous cell carcinoma, we know the marker. It's either P40 or P63, right? So then P40 or P63. Okay, that's the marker for squamous cell carcinoma. P16 is a marker for an your HPV infection. Fine. Asopati is a small cell carcinoma finding. We'll read that during lung cancer, Samantha. Fine. If you want, you can add it. Fine. Okay. Now management. Like I said in the previous class, a question should not end without management. Though the management for almost every cancer is the same, the first word in management of cancer is it's based on the stage of cancer. That means you know that cancer has TNM staging and there's different types of staging, right? Primary treatment for almost every surgical cancer is surgical resection. Like I said, based on staging, right? If it is L cell, very low grade, I have, let's say, this is a place where L cell is there. So what I do is I don't take out the entire cervix. I remove this part only, right? We have leap procedures. That's also surgical, right? If it's an H cell and if it's a very elderly person, we go for a hysterectomy. Because the false positivity value of pap smear is very high, so I cannot remove an organ based on pap smear. Okay, Vamish, if you have an LCL patient, there will be definitely nuclear enlargement in the cell which is transformed into a cancer. In the cell which is not transformed into a cancer, it will have the racinoid nucleus. In a single cell, both cannot coexist, because if it is virus infected, it cannot become a cancer. If it has become a cancer, it cannot produce a normal virus. Both are different, but both can be seen in the same biopsy. Fine. Loop procedure or an leap procedure. These are localized procedure. You would read them in your gynecology. These are localized resection, not the entire thing. HSIL or invasive carcinomas, you go for hysterectomy. Plus radiotherapy is also an advisable thing for cervical cancers. Fine. Okay, that's about cervical cancers. Fine. Let's go to the next one. Next we'll go to endometrial cancer. Same thing. I'll cover it. Can anyone tell me the risk factors for endometrial carcinomas? Anything which comes to your mind. Risk factors, you tell me, rest I'll tell. Risk factors easy, right? So risk factor for almost every endometrial carcinoma, I have two different types, but the most common one for me is your type 1 endometrial carcinoma, where the risk factor is definitely hyperestrogenism. Hyperestrogenism by default is the commonest risk factor, right? Anything which causes hyperestrogenism, primarily obesity. I would not put PCOD here for the only reason PCOD is treatable, very short-lived, not a risk factor. Risk factor will be only when this is long-lived, right? You smoke a cigarette for 2 months, it will not cause cancer. You smoke a cigarette for 10 years, it will definitely cause cancer, right? It's always long-term. That's why we can ignore your PCOD. Unopposed estrogen stimulation, obesity, and hypertension, diabetes, or you can write metabolic syndrome. The hyperlipidemia, everything comes into the term of metabolic syndrome. Infertility, again, hyperestrogenism to some extent, and mutations. Mutations especially in, if you want to write add this, post-menopausal women, which means I am talking primarily about a type 2 endometrial adenocarcinoma. Fine. Estrogen replacement therapy, yes, to some extent it can definitely increase because of, again, estrogen exposure. Fine. Smoking, again, here is an associated factor, which means smoking alone will not increase the risk, but polycyclic hydrocarbon can definitely increase the risk of your other things of can increase the risk of cancer when other risk factors are present. Fine. Okay. Yes, Teja, nulliparity again is a state of high estrogen exposure. Anything which causes hyperestrogenism will definitely increase risk, because hyperestrogenism increases the risk of endometrial hyperplasia, which in turn will increase the risk of endometrial carcinoma. So be it endometrium or your breast, both of them are hormonally dependent cancers. Both of them, this holds true. The hyperestrogenism will definitely hold true. Fine. Okay. Next, molecular classification. This is important. Again, if you want to score more, this is very, very important. For the only reason, as on date, if your college is reporting cancers, they are supposed to report in molecular classification. There are 4 different types. If you don't remember the types, just write 4 types of endometrial carcinoma. Fine. One is ultramutated or pol E tumors. Just remember one name for everything. Pol E stands for mutation in DNA polymerase epsilon. You must have remembered this in your biochemistry, the DNA polymerase. Not much, Punit. That might increase the risk of your breast cancer, but for endometrial, it's a bit unlikely. Fine. DNA polymerase epsilon stands for polymerase E, polymerase epsilon, that mutation, right? If you want to remember these 3. Hypermutated, copy number low, copy number high. Or if it's difficult to remember ultra, hyper, copy number no, copy number high, just remember the next one. Polymerase epsilon mutation, first one. MSI you will remember, right? Lynch syndrome, microsatellite instability. Third is phosphoinositide triphosphate, AKT pathway. If you remember that, that's enough. Fourth is P53, right? Either remember both, that's the best. If you're not able to remember ultra, hyper, copy number low, copy number high, remember pol E mutations, microsatellite instability, like your Lynch syndrome, a part of Lynch syndrome, right? Or your phosphoinositide triphosphate kinase pathway, which is indirectly your P10 mutation. And the last one is P53 mutated. That obviously has the worst prognosis, right? There's a new classification used for endometrial carcinoma, if possible, right? As on date, in reporting, we don't report as type 1, type 2, we report like this, fine. Let's go to pathogenesis and progression. So here the adenoma carcinoma sequence holds good. Like your colon or like anything, adenoma carcinoma sequence definitely holds good, right? So we have type 1, which happens in premenopausal, right? Or in a reproductive age group. A type 2 where the problem happens primarily in postmenopausal. In postmenopausal, can anyone tell me what type of endometrium it will be? Will it be in proliferative, secretory? What type of endometrium it will be? Postmenopausal, it will always be in an atrophic endometrium, right? It will obviously in an atrophic endometrium. All this changes happens in an atrophic endometrium, right? Because endometrium is not working properly. Reproductive age group, it could be in a simple proliferative phase. Proliferative phase is a phase where it goes and becomes hyperplastic, because secretory phase cannot become hyperplastic by default, right? A proliferative phase with the help of one classical mutation, which is P10. P10 is the most common mutation in endometrial cancer and as a first one to occur as well. It can become a non-atypical hyperplasia, right? Or if you want, right, just write hyperplasia, that's enough. But the classical name given is non-atypical hyperplasia. So once it becomes non-atypical hyperplasia, here is where your microsatellite instability and KRAS mutation happens, right? Once you have MSI stands for microsatellite instability and KRAS, it becomes an atypical hyperplasia. Again, like low grade, high grade, that's all. Same, but I use a different term. That's it, fine. From an atypical hyperplasia, I can go to an endometrial adenocarcinoma with many other mutations, at least one, remember, phosphoinositol triphosphate kinase pathway mutation. It becomes an endometrial adenocarcinoma. Okay, if you want, you can write type 1 endometrial adenocarcinoma if possible, if required, right? Second is very simple. One, from atrophy, the first person to get knocked out itself is P53. P53 by default is the worst mutation which everyone know. ARID1A, if you remember, great. If you don't remember, just write it's an phosphate kinase mutation, fine. Okay, so P53 mutation, it becomes an intraepithelial carcinoma, serous endometrial intraepithelial carcinoma, fine. Same like your SIL, it becomes an intraepithelial carcinoma. From an intraepithelial carcinoma, it becomes again type 2 endometrial adenocarcinoma. For me, again here there are multiple mutations which is there. CCNE1 is something, at least one. If you want, write, or just write telomerase mutation, or just from serous intraepithelial carcinoma, it becomes endometrial adenocarcinoma. That's more than enough, right? So these are two pathways for type 1 and one for type 2. Again, progression. If you see, this is not important for me. This names are more important for me from a postgraduate level. What is important is you have to know there is a progression. That is first thing. Second, at least one. P10 you won't forget because that's the most common. Definitely no one is going to forget about P10. Fine. Okay. So if you don't forget P10, that makes easy thing for me. And you won't forget P3. If you remember 2, that's enough for me. I know there's a 2 types, 2 different gene, 2 different progression, more than enough, right? That's for progression. Next, coming to clinical features. Can anyone tell me what will be the clinical features? You know the clinical features. What is that? It's undoubtedly post-menopausal bleeding. Even though if a pathogenesis starts in the pre-menopausal time or in the reproductive age group, for so many pathogens, for so many mutations to happen, it will by default become post-menopausal. Could be post-menopausal or a perimenopausal, in and around menopause, right? Post or perimenopausal bleeding is the exact symptom. It can be post or it can be perimenopausal bleeding. Spotting or bleeding be one and the same, fine. Yes, Sinchana, Scouting could be an hereditary cause. Okay, could be a postmenopausal spotting or postmenopausal bleeding, right? Lab investigation, once there's a postmenopausal bleeding, obviously they will investigate. Investigation is always by hysteroscopy. What does hystro mean? Hysteroscopy followed by a procedure called as DNC. This is the procedure which I want you to write for every endometrial pathogenesis. Dilatation or dilation and curettage. What do you mean by curettage? Curettage is removal, right? Hysteroscopy. Scopy is visualization. Hysto is uterus. I use it of hysteroscopy. Then you dilate the cervix, curate the entire endometrium, right? So DNC, dilatation curettage or dilation curettage, is the investigation of choice for your second year. It will be different in when you go to gynecology. For a second year, it's the, I'm not writing IOC. You're going to use this for every endometrial pathogenesis. If you have an hydrity for mole, same removal, curettage. You just curate, scrape and take it out. That's what dilatation curettage is. Then that goes into an histopathological examination. That's how it goes into histopathological examination. Fine. Then gross. Gross again, here it's inside the uterine cavity. So gross is a bit difficult, but like any other cancer, it has to grow, right? So again, you will have ulceroproliferative mass. Ulceroproliferative mass will be there in almost every cancer. If it's type 2, especially if it's a serous tumor, what is the microscopic finding for every serous carcinoma? Microscopic finding, papillae. Gross can also have papillae, can have very, very fragile papillae. Okay. Okay. Here actually there's a very good and an easy way to draw a diagram. Look for places where you can draw superb representative diagram which does not take much time, right? So here when you have a mass lesion, you draw an uterus like this. Imagine this is a cut open uterus, right, for cervix, and let's assume this is your endometrium. Okay, use a different color and say it's a mass here which is going into the myometrium. So you can easily describe that, right? I'm having a mass into the endometrium, a solid ulcerative proliferative mass which also is going into the myometrium. You can also write here there's a myometrial invasion. It's a representation. It's not how much you know. Exam is about showing off. It's how much you show to the person, right? That's for endometriosis, Punitya. Okay, so I'm having a mass here which is into the endometrium and also going into the myometrium. If you want to write tiny fragile papillae, you can also put a tiny diagram and say it's how representative it will be, right? So you cure it, it comes outside, right? Now let's go to the microscopy. Microscopy is where I want you to add the types as well. So here, since we are already discussed about the molecular way, we'll discuss about the type 1 and type 2. We already know good information about type 1, type 2. If you want, write them also. But if you want to stick to only microscopy, stick only to microscopy. Okay. If you want, write every difference about type 1, type 2, whatever you know till now, starting from age, postmenopausal, perimenopausal, you can write that. Hyperestrogenism, atrophic, if you want, you can write that. But if you want to write only the relevant one, precursor lesion for an type 1 is atypical endometrial hyperplasia, which we already drew in the diagram. And what's a precursor for type 2? There also we wrote serous endometrial intraepithelial carcinoma, right? It's serous endometrial intraepithelial carcinoma. That's a precursor lesion for a type 2, right? Type 1 microscopy is purely endometrioid adenocarcinoma. It's a pure glandular carcinoma, that's all. Fine. It's endometrioid adenocarcinoma. Okay. So in microscopy, it's an endometrioid adenocarcinoma. What do you think you'll have? The name is endometrioid. Type 1 is endometrioid. You'll have perfectly formed glands. Same glands, 4 feet of dysplasia, and obviously you'll have invasion. Here, invasion is going to be into the myometrium. Fine. Next. Serous is type 2, right? It's not just serous alone. There are multiple things here. First, write serous. Serous, as well as usual, you know, it will have papillae, it will have samoma, you can write. But there are other types. Clear cell carcinoma is also type 2. As the name says, it's clear cell. And there's one more type called an MMMT, mixed Mullerian tumor, where have both, it's, or you can write as carcinosarcoma. That's more representative, right? Carcinosarcoma, where have both carcinomatous element and sarcomatous element. There are 3 different microscopy for type 2. Fine. It's very superficial, you can draw it, right? Samoma, you can use it in microscopy if you want to represent samoma, Again, gland, if you want to represent microscopy, you can represent Samantha, fine. But these are the different microscopic appearance of type 1 as well as type 2, right? Just to finish it, IHCs. Type 1 endometrial adenocarcinomas are always estrogen dependent. So they are ER positive, PR positive. Type 2 endometrial carcinomas are not estrogen dependent, so are AR-PR negative, but they are P53 IHC positive. Write a word about prognosis. Prognosis and management gives you the extra brownie points, right? They have a decent or a good prognosis. They have the worst or the poor prognosis, right? Okay, perfect. This will easily give you, you can easily expand this and write for a page. Draw representative diagrams wherever required, but you can easily write for a page, fine. Let's go to management. Same, based on stage, either just hysterectomy, or you can remove the uterus, you can remove the parametrial glands, also the lymphadenectomy can be written. Sinchana, yes, Wymantin will be positive if I have the sarcomatous element in carcinosarcomas, fine. Since both are carcinomas, they are more keratin positive tumors, fine. Radiotherapy again, if required for extra stages, we can give, okay, perfect. That's about endometrial carcinoma, same template, it's 10-mark question, right? You can easily write. If you don't know any question asked, close your eyes. You have studied 2 years of MBBS. Can't you write 3 pages? You can. You know the word, you can easily write for 3 pages. Think, you can write something about it. Fine. Let's come to endometriosis. Endometriosis is a 5-mark question. Just give me a second. Okay. So endometriosis is a 5-mark question. Very, very unlikely for an endometriosis to come in an essay. If it comes in an essay, it's a little bit good for you. At the same time, a little bit bad for you as well. Just give me a second. Okay. So endometriosis requires a definition. Definition is something what you know in your simple words. Need not. Is it lagging? Hello. Okay. Need not have a perfect textbook definition. Write whatever it comes for you, right? Whatever it's easy for you, write them. Even if it's a single word, it's completely fine. Write them, right? So it's endometrial glands. Don't forget this. It's only glands. It's endometrial glands and stroma outside the endometrial cavity. Be it in the fallopian tube, be it in the ovary, everything is endometriosis. Fine. Okay, Samantha, like I said, it's not just endometrium. It should be endometrial glands and stroma outside the endometrial cavity. I call it an endometriosis, right? There are multiple theories, but at least write 2 of these 4. If you write 4, great. Regurgitation theory, you can easily draw a diagram and write what does regurgitation mean. During a normal menstruation, there's a possibility that the fluid can go outside the uterine cavity, right? It can go here, it can regurgitate here, and it can go to the ovaries. That's your regurgitation theory, right? It can go and regurgitate. That's one. Benign metastasis theory is the normal endometrium during menstruation. You must have read about the spiral arterioles and everything, right? There's a possibility some of the glands can escape and enter blood supply, right? Once it enters blood vessels, there's a possibility it can go and land anywhere in the body. That's your benign metastatic theory, right? Metaplastic, you know. What is metaplasia? Metaplastic theory is nothing but it's changed from one epithelium to another is metaplastic, right? So metaplastic theory is it's metaplasia of coelomic epithelium, right? So coelomic epithelium from anything can change to anything. From even from an peritoneal lining, it can change. That's the coelomic epithelium. And last one is extrauterine stem cell progenitor. This extrauterine stem cell progenitor theory gives me why endometriosis can be seen in lungs, brain, and different sites. I can see them in lungs, brain, colon, which is not even linked to anything, right? It's very, very far away. So any stem cell can become anything. So it becomes endometrium. It's your benign metastatic theory. Fine, perfect. Okay, that's your extra uterine progenitor theory, right? These two are must for minimal level, right? If you write all four, that's great. So clinical features, which is always based on the site of endometriosis, fine, but never miss this. Wherever you write endometriosis, the word should be cyclical features. If it's a lung, what do you think endometriosis of lung will present with? It's endometrium, right? It will shed with cycle. Endometriosis of lung will present with hemoptysis. It should be cyclical hemoptysis. That's very, very important, because hemoptysis can be due to tuberculosis, right? If it's cyclical hemoptysis, I think of endometriosis. Hematemesis will be from the esophagus, Shanuk. It's hemoptysis. Hemoptysis, I think of it. Hematemesis could be anything from the GIT. I won't think of a lung. Fine. Colon, again, cyclical, hematochezia or bleeding, right? If it's cyclical, bleeding per rectum, I can easily call it an, or if you know what is hematochezia, it's nothing but bleeding per rectum, right? So I can think of an colonic endometriosis. Chocolate cyst of ovary, it will be a painful thing because it's an ovarian lesion, right? Ovary cannot bleed outside, it will bleed inside again and again and again. That's why you're going to have your just dysmenorrhea, cyclical, very, very intense abdomen pain, like the case what we saw in the start, right? Cyclical dysmenorrhea, extreme intense abdomen pain, everything cyclical, you think of an endometriosis, right? Gross. Someone told in the gross few minutes back, anything in gross based on the organ, again, you will have hemorrhagic spots. Again, one thing don't forget here, since the most common site is ovary, at least there you have to write a little bit of words about that, right? So here, if it's an ovary, outside or the outer surface of the ovary, you can see the spots. This is called as powder burn spots, like a gunpowder burn, right? Or the blackish brownish spots is what powder burn spots is. Fine. See, if you shoot, the gunpowder comes back and produce tiny kind of an very tiny burn injury in the person who shot, like a powder burn, right? That's powder burn spots. That's how the outer surface of endometriosis looks like. On the cut surface, it will be completely hemorrhagic, filled with blood, and that's altered blood that kind of looks like an brown color. So we have the term chocolate cyst. This is must. If you want to add how it looks in colon, add. How it looks in your brain, add. Lungs, add. But this is something which is very basic and very important. High plexor. Okay, that's about gross. Microscopy is simple. Whichever organ it is, you will have endometrial glands and stroma. Stroma is very, very important. Okay, stroma of the endometrium is a spindle-shaped cell. If you want to draw a representative structure here, I'll tell you very easy ways to draw things. Draw an ovarian very flat epithelium. Say it's an ovarian epithelium, and here you have glands, tiny glands here. The most important thing is surrounding the glands, I want you to draw good amount of spindle-shaped cells or elongated cells. That's your endometrial stroma. Fine, something, and this is your normal ovarian lining. Just write there's an endometrial gland and stroma in ovarian lining of endometriosis. Powder burn spots, right? It's a gunpowder burn spots. IHC, the glands of the endometrium, they are ER/PR positive, especially in a colon or a lung. That helps a lot. And the stroma of the endometrium, it's positive for CD10, right? So this helps for us to understand, okay, it's most likely endometriosis and not any other gland, right? That's CD10 is more important marker than your ER/PR. Hi Vaishnavi. What is arrow? That's the arrow. Just a gland and a representative stroma, Samantha, that's all. Fine. That's about endometriosis. Now let's go to breast cancer. Fine. That'll be the last thing we'll be starting. Vaishnavi, you asked the same question yesterday also. First year has been started. Please go and have a look at the MedEd app. Okay. So tell me, what are the risk factors for breast cancer? Breast cancer is definitely a very important question, right? What are the risk factors for breast cancer? Risk factors for breast cancer. Nulliparity is one, age is one. Anything else? Age, excess estrogen, early menarche, BRCA mutation, family history. Perfect, right? So now what it makes sense here is, for a breast cancer alone, I want you to write a risk factor based on the relative risk. This is very, very important. A relative risk of more than 4, a relative risk of less than 2, RR stands for relative risk, and a relative risk of 2 to 4. This is what it means for breast cancer. Because breast cancer history relative risk is very important. So this gives you a very clear understanding. You need not write again what is more for which gene is more. Everything is included here, right? Female gender, age, and a very strong family history. What do I mean by strong family history? Is more than one first degree relative. Just a family history means just one first degree relative. Okay, that's the difference between strong and very strong. High breast density, and these are the genes. These two are must. BRCA1, BRCA2, CDH. Tell me which cancer has CDH mutation? CDH will have the lobular carcinoma, right? Have the lobular carcinoma. That's important. This don't forget. Other things, if you write or don't write, these are extra, that's all. P10 for Cowden syndrome, STK11 for Peutz-Jeghers syndrome, TP53 for Lee-Romney syndrome. But first three is very, very important for it, right? And these have very high risk, more than 4 relative risk for breast cancer. Then 2 to 4, high dose radiation to the area, chest area, family history of one relative being affected, and your ATM and check mutations are 2 to 4 relative risk. Less than 2 is what? Everything what he said. Less than 2, the primary premise is increase estrogen levels. Fine. Increase estrogen levels is a primary premise for less than 2. Early menarche, late menopause, a late first pregnancy, nulliparity, absence of breastfeeding, exogenous hormones, postmenopausal obesity, everything. Everything hyperestrogen comes in less than 2, and you have 2 to 4 and more than 4. For breast cancer alone, write more about the etiology, because the pathogens of breast cancer is not much taught in your second year of MBBS. It's more on etiology is where we focus, and pathogenesis we don't focus much, at least for second year of MBBS, right? So that's about the etiology. Now, why I said we don't focus much on pathogenesis and progression of breast cancer is a bit complicated for second year student to understand. You will definitely learn that. You will definitely learn that when you go to your final year, when you go to surgery, because surgery breast is one of the most important topic. You will definitely read that. There's nothing to worry about, right? So if you want to write about the progression and the pathogens of breast cancer, try to keep it simple. One thing you know, normal DCIS, then it becomes a carcinoma. That's how you must have read, and you must have already known that, right? So if you want to write a little bit more about the pathogenesis, and if you want to use all the genes and everything in the pathogenesis, try to write this if possible, fine? From a normal breast parenchyma, okay, there are two ways. I can have a very good or a luminal A type of a cancer. I can have a very poor cancer also, right? So what happens is, breast cancer, if it's going to become a very normal luminal A type of breast cancer, BRCA mutations is some of the most important thing. Okay, it causes flat atypia. Again, it's atypia, that's all. This flat atypia with again phosphoinositol triphosphate kinase mutation becomes atypical ductal hyperplasia. It's same hyperplasia. This hyperplasia becomes your DCIS, ductal carcinoma in situ. That becomes an IDC, invasive ductal carcinoma. That's for predominant of them, right? There is one more pathogenesis where P53 is primarily involved. Here, P53 mutation, and second is HER2 amplification. This also can result in a cancer. I don't have a very defined precursor here. Becomes directly an DCAS, then becomes an IDC. This is your HER2 new only amplified breast cancers pathogenesis, fine. Strong family history means when I have more than one person affected by breast cancer, strong family history, Samantha, fine. Then I have this triple negative. Triple negative, the most important thing is BRCA1. So BRCA1 mutations. When I have hereditary BRCA1 mutations, that's the most important thing here. And also to add it, TP53 mutations. Okay, that becomes your DCIS, and that becomes IDC, right? Ultimately, this is how it becomes IDC. Fine. Now the question is how BRCA mutation is going to increase the risk of cancer, right? Two important factors here. Estrogen will increase cell division. That's what estrogen is known to do, right? BRCA1 and BRCA2, when they are lost, or when they are BRCA1 and BRCA2 mutation, the normal role of BRCA is DNA repair, homologous DNA repair. That's what they do, right? When BRCA1 and BRCA2 is mutated, it results in less DNA repair or no DNA repair, right? So when there's an increased cell division, there's increased chance of a repair. In addition to that, I have a force which is not letting my cells repair properly. That increases the risk of cancer formation. That's what actually it does, right? So I have progression as well as we have a little bit about the pathogens of breast cancer. Fine. That's about breast cancer pathogens. In breast cancer, the etiology and the microscopy is more important than the pathogenesis. Fine. Let's come to clinical features. I'm sure you know. Can anyone tell me the clinical features? Clinical features. Simple, right? It's going to be a breast mass, mostly a painless mass in the breast. That's a classical clinical feature of breast cancer. It could be a very irregular firm mass. You can add what all you want, plus or minus axillary lymph nodes. Lymph nodes can be there, may not be there. Puckered skin, purity orange, blood discharge, retraction of nipple. These are also findings seen in breast cancer. You can write, because I am sure everyone must have seen at least one breast cancer patient in your surgery postings, right? One at least you must have seen. That's more than enough for us. Investigation, mammogram, if there is no palpable mass. If there's a palpable mass, no one is going to do a mammogram. Hold the tumor, take a biopsy. If there's no palpable mass, if you're suspecting DCAS or is in risk of cancer, then do a mammogram. If there's a palpable mass, do a biopsy. No FNAC, FNA is not required. Directly go for a biopsy, right? Gross. Gross, again, it's a very, very, very firm tumor. From an undergraduate, we expect this term. It's serous carcinoma of breast, right? It's a serous carcinoma. It's a very firm tumor. It's unencapsulated. It's infiltrative. In case of an infiltrating rectal carcinoma, we expect the term serous, the strong nature, and the infiltration, at least we expect them. It's very solid tumor. You won't have cystic lesions or solid gray tan tumors, how most of the breast cancers are. Mucinous carcinoma can be a little bit mucinous and fleshy. Otherwise, it's predominantly solid. Fine. Okay. Next, microscopy. This I want you to keep in mind. Take a screenshot of this whenever you are preparing. I'll give you the PDF anyway for you. See this before the day of the exam. I'm going to write 1 or 2 features for everything. Sorry, I'm going to write 1 or 2 features for every tumor here. Fine. Okay. IDC NOS is very simple. So you're going to have irregular tubules. Irregular tubule formation, plus obviously invasion will be there. That's by default present for every carcinoma here, right? Irregular tubule formation is a classical finding seen in case of an infiltrating rectal carcinoma. Your infiltrated rectal carcinoma, not otherwise specified. When you have the term mucinous carcinoma, you will have pools of mucin with floating tumor cells. Cells will be very, very less. It will be more mucinous and very, very less cells is what you're going to see in mucinous carcinoma of breast. When I take tubular carcinoma breast, this most well differentiated. It's very well differentiated. I'll have well formed tubules. Sometimes it's a bit difficult to differentiate tubular carcinoma from a normal breast parenchyma, right? Well formed tubules, very well differentiated. We think of a tubular carcinoma. Papillary, you know. You'll have papillae, and obviously whenever it's papillae, you can write some homobodies. right? Next, write this papillary carcinoma. There's an increased risk of metastasis. These are one feature that's important because it's papillary. There's an easy chance it can break and spread outside. There's an increased risk of metastasis in case of papillary carcinoma. Medullary. Medullary means it is soft. That's the first word. It's not serous. Most of the medullary carcinomas are soft. Medullary carcinomas, they don't infiltrate. They have a pushing margin. They don't infiltrate, right? They push. When they don't infiltrate, I won't have much of desmoplasia. That's the reason it's soft, right? Medullary carcinomas have a pushing margin. Medullary carcinomas have a surrounding lymphoplasmacytic infiltrate. That's very, very classical for a medullary carcinoma or a medullary-like carcinoma or carcinoma with medullary features, right? And the third thing, medullary carcinoma has solid sheets of cells. It's not like tubules. They are more of solid tumor cells, solid sheets of tumor cells. Okay. Medullary carcinomas are generally triple negative and they are associated with BRCA1 mutation. Medullary carcinoma is soft, they are pushing model, and they don't have a good prognosis. They are most often triple negative tumors. Right? Again, what do you mean by metaplastic? Metaplastic is change, right? So here you have these tumors. I'll have definitely IDC plus you might have squamous differentiation plus you might have spindle cell differentiation, right? That is metaplastic. It moves to squamous, it moves to spindle cell. That's metaplastic. No, Devankan mucinous is a very good tumor. They have a very good prognosis. They have very less tumor cells, more mucin, and the mucin does not flow outside. It stays inside. They have very good, well prognostic tumor. Quite a few of among this mucinous tubular have very, very good prognosis, right? Inflammatory carcinoma is not actually a microscopic finding. Inflammatory carcinoma is a clinical term. Okay, it's IDC only with clinically an enlarged or an inflamed red breast because of the subdermal lymphatic blockage. The lymphatics are blocked. That gives an inflamed appearance to a normal breast parenchyma, skin thickening, swelling, erythema of the breast. That gives the term inflammatory carcinoma. It's a normal IDC only, right? Lobular carcinoma, you know, there's no gland formation, there's no tubule formation, and you have the Indian file pattern or an Indian file appearance. The cells one behind the other. If possible, for all this, draw a little bit of representative diagram. If you cannot draw for everything, draw for this and draw for this. Just a tubule, that should be more than enough, right? For breast cancer, I want you to know the grading. Modified Bloom-Richardson, which is expected. If you find difficult to remember this, it's same like TNM. But instead of tumor, node, and metastasis, I have a different thing. Tubule, nuclear pleomorphism, and mitosis. Based on this, we have a grading. Based on tubule formation, nuclear features, and mitosis, grading is done. If you write this, that's enough, right? Draw. What does draw means? What, Samantha? Right? It's drawing, fine. If you want, you can draw it. A single Indian file pattern or a tubular appearance, right? It's tubule formation, nuclear grading, and mitosis. We give a grading of 1, 2, or 3 based on the prognosis alters. Breast cancer answer sheet will never end without molecular classification. It is must. Whether they are asking or not, please do write molecular classification. That's very, very important. 3 markers plus 1 extra if possible, right? Ki67. Luminal A, luminal B, HER2 new only, and triple negative. These are things which you have to remember. This alone can itself come in a 5 mark, right? Molecular classification of breast, normally it's done on gene expression profiling. Okay, that's the ideal way to do it, a gene expression profiling. But we don't have that, so a surrogate finding is immunohistochemistry. We go for that because it's easily available, that's all. If you've seen Robbins, in breast cancer chapter, have you seen some images with red color, green color? That's actual gene expression profiling. That's an image of that, right? But here we don't use that. We use markers to identify them, that's all. Luminal A is ER/PR positive, HER2 negative, K less than 14. K less than 14% is luminal A. They have the best prognosis amongst every cancers. Every type here, they have the best prognosis. Luminal B is of two types: ERPR positive, HER2 negative, Ki of more than or equal to 14% is luminal B. At the same time, if you have ERPR positive and HER2 positive, any Ki system, it's also luminal B, right? This is also the most common as well. The most common subtype is also luminal A. The best prognosis is also luminal A, which is at least something good for the patient, right? Both of them will be luminal A, and luminal B also has a very decent prognosis, little bit less than your luminal A, but we definitely have a good prognosis. It's not bad. Most of them, they do have a good prognosis, fine. HER2 new only negative for ERPR, as the name says, only HER2 positive, any Ki. The only good advantage of HER2 new is you can give a targeted therapy. You can target, you can give an trastuzumab or an HER2 new. In your pharmacology, by this time you must have read about cancer chemotherapy. You can write, if you want to write more for the management, you can definitely write it, but a pathologist doesn't require that. They'll at least expect your trastuzumab or a Herceptin targeted therapy, fine. Triple negative is all three are negative. Again, Ki67 doesn't matter, any amount of Ki67. So here they have the worst prognosis of all. Most of the BRCA1 positive, BRCA1 related tumors are HER2 are triple negative, and here only chemotherapy will help. No hormonal therapy, no trastuzumab, only chemotherapy, platinum based chemotherapy. That's how most of the HER2 triple negative tumors are, right? But this is very important. Without this, don't end it, and this itself can come in an answer, right? If you want extra points, again only if you want, right? There are few, see, one is classifying them molecular, one is classify them microscopically. So when I see microscopy, I can guess the molecular profile. Like I said, if you see medullary pattern, generally it will be triple negative. So add this, especially if it comes in a 5 mark. If the 5 marks question is asking molecular subtype of breast cancer, write this and add to it luminal A microscopy wise will be tubular. If microscopic is tubular, very good prognosis, luminal A. Mucinous, luminal A. Papillary, luminal A, right? Lobular, low grades. Low grade lobular, also luminal A. Okay. High grade lobular, luminal B. When I say high grade, according to Blue Richardson or the high grade tumors, a high grade lobular tumor will be luminal B. Microscopy wise, again this is matching. I can definitely have very rare case of tubular becoming luminal B also, but most of the time this is how it is, fine. HER2 new enriched, micropapillary is HER2 new enriched, and there's a type of carcinoma called as apocrine carcinomas. That's also HER2 new enriched. Okay, triple negative, I told you one more thing already, medullary. Medullary microscopy can be triple negative. Metaplastic microscopy can be triple negative as well. Okay, again these are only, see, if it's a part of a long answer, don't spend time to write this, but if it's only a short answer, molecular classification alone, write this, right? This might definitely help you, fine. It's just for extra pointers, fine. Okay, again to end, management. I don't think so I would need to tell you the management of breast cancer. You must have at least seen 1 or 2 presentations of breast cancer in your surgery. You definitely will know management more than me. Mastectomy, axillary lymph node dissection, with or without. If you want to write a little bit more, use the terminology sentinel lymph node dissection. With that, you can definitely add it, but just a word. Instead of surgical resection, write MRM, modified radical mastectomy, to be done, right? And radiotherapy, if it's involving the pectoral region or anything, you can give radiotherapy, fine. Okay, that's about the breast cancer, fine. That's for today. I didn't talk about सब लोग MBBS में हो दर्शन, fine. सब लोग इधर डॉक्टर है. Yeah, Samantha. Color pen. I'm not a person favor of color pen. Right? If you are good in normal black and blue, that should be more than enough. 2, at least 3. Just 2. 1 for heading, 1 for the text should be more than enough. But if you feel that you're more obsessed with color, go with that. Fine. Okay. Tomorrow, a developer rule king. Wait, I'll see. Tomorrow I'll be talking about CVS and law. Okay, I'll give you what to read in the day. I'll take few important things in the evening, and you have the Farre PDF with you, which has most of the previous questions. Just have a look at them as well. Drawing is, see, drawing is again totally left to you. If yours in an hematoxylin, like I said in last class, it doesn't break, it's good. Or just take a pink and blue Luxor pen, that should be more than enough. Fine. MRM is a surgery, modified radical mastectomy. Vamesh, I will put this PDF in the Google Drive. The Google Drive link is both on my Instagram channel and on the WhatsApp group. Okay, and it will be also in the app. So wherever you want, if you are not using social media, download the app. In the app, there's a batch called Farre 2.0. In the Farre 2.0, the annotated notes will be there. Fine. Sure, I'll do it. I do it. Fine. Okay. Raju, I'm not the right person to talk about NEET UG. There are very, very good teachers better than me to guide in that. So go to the PW main channel. If you're into NEET PG, we'll definitely talk about it. Okay. Thank you guys. Bye-bye.